My topic is a little broad, so I probably crammed too much information into the slide set. But if there's any questions, I'll be happy to answer them at the end. And in the last year, we've added another physician who also works in sickle cell clinic with Dr. Patterson and myself, and Dr. Prairie joined us about a year ago. So we're happy to have her in sickle cell clinic as well. The newborn screen letters go back to the primary care physicians and to the families, and they actually have to refer to us for us to see the child. So that contact, we do not get the direct newborn screening results of our program. So most of the physicians refer in the agricultural hospital. So next slide, please. This is an overview of what happens with normal red blood cells on the top and with sickle cell on the bottom. And it shows that as the sickle cells sickle, we end up including small capillaries, and blood flow to tissues is not what it should be, and we end up with pain and damage to tissues. Next slide, please. In this disease, you can't be a hematologist unless you put a blood smear on the slide. So these are the pathognomonic sickle cells that were first described in the 1920s, and they actually damage the walls of the blood vessels and actually clog up and getting blood flow to our tissues. They also break down faster than they should, which leads to the anemia associated with sickle cell anemia. The hemolysis or breakdown of red blood cells also causes its own set of damage to cells, aside from decreasing oxygen tissues. Next slide, please. We've already heard about the increased risk of infection. I sometimes feel that I grew up with sickle cell disease. If you look at the dates on the slide that Dr. West demonstrated, I finished medical school in 1989, about the time when newborn screening was really taking off, and about the time when prophylaxis became the norm for children with sickle cell disease. Before that, most of these children were not placed on penicillin, and so death from sepsis was very common in that era, and I remember seeing that in medical school and also during residency a lot differently than we see today. We've also been blessed with immunization improvement. In addition to the compliance with the penicillin, our vaccines are better. If we go back to 1989, when these recommendations, there was only one vaccine for pneumococcal disease, and that was Pneumovax. And if you can give it to children less than 2, but it doesn't work because their bodies are not able to make antibody to vaccines of that type. Over the years, as we've taken care of kids with sickle cell disease, we have developed vaccines that are also given to all children that help prevent pneumococcal vaccines. Originally, we have Prevnar, and now we have 13-valent pneumococcal vaccine that is given to all children, including kids with sickle cell disease, and our rate of infections with encapsulated organisms has decreased over time, in addition to the pen prophylaxis. In Sickle Cell Clinic, one of the roles we play is education to families regarding what to do with a child with sickle cell disease. Because of the increased risk of infection, we encourage parents to have them seen by their physicians if they develop fever greater than 101. Whereas we all know that with kids who don't have sickle cell disease, many times we say, oh, give some Tylenol, see if it comes back. But we don't do that with children with sickle cell disease. Next slide, please. Painful episodes, and pain is pathognomonic for sickle cell disease, and the rate of pain crisis varies among our patients. We do a lot of education about avoidance of triggers for pain. We know that kids and adults, when they're exposed to cold, anything that decreases our blood supply to our extremities causes them to have sickle pain crisis. That can be making snow angels or diving into icy pools before it really gets to be July in Arkansas. Anything that causes dehydration puts them at risk for having painful episodes, so we encourage hydration and avoidance of caffeine-containing products. So in Sickle Cell Clinic, we talk about how we're going to manage pain at home with increased hydration orally. We talk about using ibuprofen and non-steroidals, and we provide prescriptions for narcotic level pain control when the pain can't be controlled with ibuprofen. We're involved when the kids present to Arkansas Children's Hospital with ER management, and the hematology staff is also available to doctors
across the state of Arkansas if they need help with ER management or inpatient management of painful episodes. One of the goals, and my last slide demonstrates some changes at Arkansas Children's Hospital. One of our goals is to have, currently for acute painful episodes, because of lack of clinic space that we've experienced over the years, is to have more of these kids able to come, especially during the day, to the hematology clinic so that we can get them plugged into pain control faster than going to the emergency room. We're still probably about a year off from that, but you'll see some of the changes we've got coming. Next, please. Over time, as we've been taking care of kids with sickle cell disease, we've started using more hydroxyurea. This drug increases fetal hemoglobin, which we heard about on newborn screen, and upregulates fetal hemoglobin, lowers the white count, lowers the platelets, decreases the clogging of those blood vessels, and many patients experience decreased painful episodes, less anemia. You can actually tell when patients are compliant with hydroxyurea. Their hemoglobin goes up. Any cell that has more fetal hemoglobin is bigger than cells that don't. And so you see that their anemia gets better, and they have decreased hospitalizations, decreased pain episodes, decreased acute chest, decreased need for transfusions. And we wonder about, remember, the breaking down of those red blood cells damages our organs as well as the anemia does. So right now we don't know the long-term benefits of decreased chronic organ dysfunction. We've seen that more over the last 10 or 15 years as we see more and more people making it through the pediatric age range into adults and learning about chronic diseases associated with sickle cell disease as they get older. There are some negatives about the use of hydroxyurea, including increased need for visits to the hospital to check, or to a physician to check blood counts to make sure we titrate the dose correctly. The need to take medication every day, and a lot of times in sickle cell, patients are taking medicines when they experience pain, and so learning to take medication every single day after they're off penicillin is a different role. And we still worry about long-term risk of myelodysplasia from prolonged use of hydroxyurea. One of the risks of sickle cell disease, and one of the ones that bothers me the most, is the increased risk of stroke in this patient population. We know that the risk of having a clinically overt stroke, meaning we can tell that you're having something go wrong because you don't talk correctly or you don't move an extremity correctly, is between 5 and 12% before they exit from pediatric care. There is still a risk of stroke in the adult age range, but it is less than that in pediatrics. We've also learned over the past 5 to 10 years about the risk of silent infarcts, strokes that we can't see, but there's probably none of our brain that we don't need. And so we've learned that school failure problems and problems with attention are linked to having infarcts or strokes in areas that we can't tell on physical exam. As our imaging studies have gotten better, as we've moved further and further through medicine, we see more and more silent infarcts, and depending on which study you read, it ranges from 20 to 40% the risk of silent infarcts in patients with sickle cell disease. Research has also led us to doing head ultrasounds, and that's what's going on with the patient now. Just like when you're pregnant and you get an ultrasound, we can ultrasound the vessels in your head and actually measure blood flow. And we know if blood flows fast through your middle cerebral artery, if your blood is faster than the cutoff, then you're at 50% risk of stroke rather than 5 to 12% risk of stroke. If a child with sickle cell disease has a stroke, we put them on chronic transfusion and keep their sickle hemoglobin less than 30% indefinitely. If we know that your risk of stroke is 50%, we offer that same level of support to those families. Many accept that, some don't. Next slide. This is erythrocytophoresis, and this is Linda Owens, one of our apheresis nurses. I think Sanji has departed, but both of the apheresis nurses are here. We're blessed at Arkansas Children's Hospital to have the availability of the technology. This is the machine. The Cobe Spectras are about $100,000, so this is not an insignificant investment for a hospital, and that's why certain children's hospitals across the country really don't have the availability. But with this machine, we can actually decrease sickle hemoglobin from roughly approximately 100% sickle to less than 30% in 100 minutes. And for my children that have had stroke, they come in about once a month and get erythrocytophoresis. My primary, and we'll talk briefly, mention iron overload. The beauty of erythrocytophoresis versus straight transfusion is that we're removing blood cells, the old red blood cells, the sickle red blood cells, and giving back hemoglobin A in normal red blood cells. And so we remove iron. One of the problems with chronic transfusion support in sickle cell is we cause iron overload with our therapy. So we use this for prevention of secondary stroke, which means the child had a stroke and now I need to keep the same thing from happening again. And we also use it as prophylaxis if you have a primary transcranial Doppler. One of the things we don't know is what is the role of blood transfusion versus hydroxyurea in those silent infarcts. Nobody knows what the optimal therapy for that. And there's several studies, including the silent infarct transfusion trial, which we participated in at Arkansas Children, but the data will not be available until summer 2013, so nobody knows. But we did participate in the research trials that will give us the answers to that. We also use it for treatment of acute chest syndrome when patients have rapidly progressing respiratory problems. Next, please. I've got two slides that just roughly go through the side effects of sickle cell disease. And remember, it affects all organs. This is a picture. If you look, you'll see the fingers look fatter than they should. This is called dactylitis. And it's involvement of the feet and hands with swelling, common in very young children with sickle cell disease. That older children don't typically experience dactylitis. This reminds us that gallbladder disease is common anytime you break down red blood cells with hemolysis. So the risk of having gallbladder disease is almost 50% before you exit pediatric care, which, if you think about it, for most kids, gallbladder disease is sort of something you get when you're closer to my age than closer to pediatric care. The chest x-ray shows us any kind of infection, pneumonia can trigger acute chest syndrome, areas that don't get enough oxygen, and it can rapidly progress, but much faster than pneumonia progresses in patients without sickle cell disease because those areas have decreased oxygenation. The next picture is a leg ulcer, which in pediatrics rarely happens to children without sickle cell disease, but areas of minimal trauma like a mosquito bite or one of my kids dropped a can on their ankle can cause a break in the skin and lead to leg ulcers. The little girl to the right demonstrates the spleen in sickle cell disease. We know it doesn't work as well as it should. It doesn't filter infections as well as it should, but it can also suck up to half to 2/3 of your blood volume. So instead of being in your blood vessels, it suddenly swells up and your blood volume goes to your spleen and you have acute splenic sequestration crisis. Next slide, please. This shows us some of the bony complications of having sickle cell disease. Because you have to make so many red blood cells, you're anemic. Your reticulocyte count is increased. And so your bone marrow, you can see this calvarium should not be quite that thick. It should be 1/3 of that. And so you see the thickening of the calvarium of the skull in sickle cell disease. This one shows you the hips. There's only one artery taking blood supply out to the hip joint. And if those have recurrent sickle cell problems, they can come in complaining about pain, and you think they're just having a pain crisis. But when you actually do films or plain films usually give us the answer, but when they don't, MRI does. And they get avascular necrosis of the femoral head. And again, very rare in pediatrics, except in the sickle cell patient population. The next picture shows us the humerus, and it has the same limited blood supply as the femur. And so you get avascular necrosis of the humeral head. This picture in blue demonstrates, remember the picture of the child with dactylitis? The reason for the pain in sickle cell disease is you actually infarct the bone. And so you actually end up with bony changes on plain film several days after you have a painful episode. And this is showing us changes in the bone after a painful crisis or dactylitis in the child's feet. I don't know how well this is projecting, but you know how vertebral bodies are usually flatter? And you see how these are kind of gapped apart. Those are called H vertebral bodies, or there's another word in the textbooks, is fish mouth vertebral bodies, related to bony infarcts in the spine and sickle cell disease. And you'll see x-ray reports coming out from radiology with from a chest x-ray saying the typical findings of sickle cell disease in the vertebral bodies, and that's what they're talking about. Next. And we talked about, mentioned iron overload. Many of the therapies in sickle cell disease involve transfusing blood. And prior to about 5 or 6 years ago, the only product that would take iron out of your body was Desferal, and it was very inconvenient to use. You either had to give it IV or sub-Q, and IV was continuous infusion for 10 to 12 hours a night for 5 to 6 nights per week. So the kids were hooked up to infusion pumps at home. You can imagine what compliance with that looked like and how much kids wanted to be like everybody else. Now, we also participated in the research trials looking at XJ, which is an oral chelator, which once a day, mix it up, drink your XJ, and it chelates, which is a much better product and much better tolerated. And now this is what I was referencing, changes at Arkansas Children's Hospital. You've probably seen on the news, this is the new South Wing of Arkansas Children's. Apparently $121 million later, we have new clinic space. Okay, this is actually the new Circle of Friends clinic. The entrance into our pediatric hematology oncology clinic goes live with 3 halls, so we can have much more space to see patients. If you've looked at Arkansas Children's Hospital lately, we had to split hematology oncology with our hematology, sickle cell, and hemophilia services, clot disorders, moving down the street to Circle of Friends, which was inconvenient for a variety of reasons. And now we'll all be back together in Hemonc Clinic, which is on the first floor of this new building, with about 6 times more space than we've had.
It went from 5 to 12,000. From 5,000 square feet to 12,000.
The numbers are there. So, back, you didn't get to see my unit. Okay, these are our new patient rooms. We got 26 private rooms, which we are thrilled. I'm tired of patients fussing at me when they get put in a semi-private room. And then this is the atrium space that the rooms overlook. So we're proud of our new space. We think it will allow us to improve patient care and also increase availability and hopefully lead to improved services over the next couple of years.
Yeah.